Hemolytic anemia occurs due to premature destruction of RBCs. At the end of this video, you should be able to know how this happens, a little bit about why, and the differences between intravascular and extravascular hemolysis. I am Nabeel and this is Pathologist. In all hemolytic anemias, RBCs are destroyed prematurely. That means the lifespan of RBCs is reduced from the usual 120 days, which causes anemia, which in turn causes hypoxia. This stimulates the kidneys to produce erythropoietin. Erythropoietin stimulates the bone marrow to produce more RBCs. So erythropoiesis is increased. This forces more and more young RBCs to come out into the circulation. These young RBCs are called reticulocytes. And reticulocytosis or increase in reticulocytes in the peripheral blood is a hallmark of all hemolytic anemias. Hemolysis or destruction of RBCs can be extravascular or intravascular. Intravascular hemolysis occurs within the blood vessels, while extravascular hemolysis mostly occurs in the spleen or sometimes in the liver, bone marrow, etc. Let's first look at extravascular hemolysis. Extravascular hemolysis mainly occurs in the spleen. Within the spleen, RBCs have to navigate through tortuous, narrow splenic cords. And this requires RBCs to be really flexible or deformable. All along these narrow passages in the spleen are macrophages which are waiting to eat up anything which is abnormal. Normal RBCs are generally deformable and go through this without much trouble. But if the RBCs are not deformable due to inherited conditions like thalassemia or G6PD deficiency, these RBCs will find it difficult to go through these splenic cords. And when the RBCs struggle to go through these splenic cords, they are eaten up by splenic macrophages. This is extravascular hemolysis. So what are the clinical features you see? Since most of the RBCs are eaten up by splenic macrophages, patient will have anemia. And since spleen is doing most of this work and more macrophages eat up RBCs, spleen enlarges in size. So you get splenomegaly. And when more and more RBCs are destroyed, heme in the hemoglobin gets converted to bilirubin and you get jaundice. Now let's zoom into these macrophages and try to look at some special investigations you do in cases of extravascular hemolysis. These splenic macrophages eat up the RBCs. And when the RBCs are destroyed within the macrophage, hemoglobin is released. Although most of this hemoglobin is contained within the macrophage, a little bit can escape into the circulation. The free hemoglobin in the circulation is dangerous. It immediately attaches to haptoglobin. So haptoglobin levels will go down as some of it is used for containing the free hemoglobin in the circulation. Now most of the hemoglobin gets converted to bilirubin and this escapes into the circulation causing bilirubinemia. And since this occurs before reaching the liver, what we get is unconjugated bilirubinemia. Till now, we have learned that hemolytic anemias are due to premature destruction of RBCs, which in turn increases erythropoietin, and because of increased erythropoiesis, you get reticulocytosis, which is a hallmark of all hemolytic anemias. Then we learned that hemolysis can be extravascular or intravascular, and that extravascular hemolysis mainly occurs in the spleen, while intravascular occurs within the circulation. Then we saw that when the RBC deformability reduces, splenic macrophages eat up these RBCs. And that is how extravascular hemolysis occurs. Because of all of this, patients have anemia, splenomegaly, and jaundice. Then we saw that the RBCs which are eaten up by macrophages release hemoglobin, some of which reaches the circulation, but it is taken up by haptoglobin, because of which haptoglobin levels decrease. And that heme finally gets converted to bilirubin, causing unconjugated bilirubinemia. Now let's look at intravascular hemolysis. Here RBCs are destroyed within the circulation. So hemoglobin is released into the plasma. If lot of RBCs are destroyed within the circulation, hemoglobin in the plasma increases. And as we saw earlier, haptoglobin will bind to all this free hemoglobin. But as the load of free hemoglobin within the circulation is very high, haptoglobin levels reduces severely. This free hemoglobin can reach the kidney and get out through the urine, causing hemoglobinuria. And some of this hemoglobin gets converted to hemosiderin and gets released in the urine, causing hemosiderinuria. One interesting thing here which you need to notice is that spleen is not involved anywhere. So you don't get splenomegaly in intravascular hemolysis. Let's look at some causes of intravascular hemolysis. It can be due to mechanical trauma on RBCs, due to heart valves, maybe in marathon runners because of RBCs constantly getting hit onto the blood vessel walls. Toxins. Some toxins can directly destroy the RBCs. Parasites like malarial parasite, or in some cases complement, can get attached to the RBCs and destroy it. Now let's look at some features which are common to all hemolytic anemias. When lot of RBCs are destroyed and hemoglobin is released, bilirubin is increased. And since this occurs before reaching the liver, you get unconjugated hyperbilirubinemia. Free hemoglobin in the circulation is taken up by haptoglobin. So haptoglobin levels reduces. When lot of RBCs are destroyed, hemoglobin can reach the circulation, and this is taken up by haptoglobin. So haptoglobin levels reduces. All the heme from hemoglobin is converted to bilirubin. So you get increased bilirubin levels, basically unconjugated bilirubin. And since the liver processes all of this bilirubin, there is a high chance for the patient to get pigment gallstones within the gallbladder. Now, because of anemia, erythropoietin production is increased, and it forces the bone marrow to increase the number of precursors of RBCs. This results in erythroid hyperplasia within the bone marrow. And because of erythroid hyperplasia, many young RBCs are released into the circulation, causing reticulocytosis. Now let's look at the morphology of hemolytic anemias. In peripheral blood smear, you get anemia, obviously because most of these RBCs are destroyed. Now, morphologically, most of these cells are normocytic, normochromic only. But along with these cells, you get these larger cells which are actually younger RBCs, which retain the RNA within them. So these are called reticulocytes. So you get normocytic normochromic anemia with reticulocytosis. And if the reticulocytosis is very high, you might get a macrocytic blood picture. In intravascular hemolysis, since RBCs are destroyed within the circulation, you may see broken RBCs. They are called schistocytes. And as we saw earlier, you get erythroid hyperplasia in the bone marrow. And when the hemolysis is chronic, all the released iron from all these RBCs start getting deposited in various organs in the form of hemosiderin. So it can cause hemosiderosis. To conclude, let's look at the main differences between extravascular and intravascular hemolysis. First, site. Of course, extravascular hemolysis occurs within the spleen, liver, bone marrow, etc. and RBCs are eaten up by macrophages, while intravascular hemolysis occurs within the blood vessels. Hemoglobinemia or increased hemoglobin in the plasma. As most of the hemoglobin which is released after the destruction of RBCs in extravascular hemolysis is within the macrophages, hemoglobinemia usually does not occur in extravascular hemolysis, while in intravascular hemolysis, hemoglobinemia occurs. As all the RBCs are destroyed within the circulation and hemoglobin is directly released into the blood. Hemoglobinuria. As there is no free hemoglobin in extravascular hemolysis, hemoglobinuria does not occur. While in intravascular hemolysis, the free hemoglobin goes into the kidney and comes out through the urine. So hemoglobinuria occurs. Hemosideриnuria. This hemoglobin in the urine in intravascular hemolysis will be reabsorbed and iron will get deposited in the kidney in the form of hemosiderin, which again gets released into the urine, causing hemosideриnuria. This does not occur in extravascular hemolysis. Now let's look at haptoglobin levels. Since in extravascular hemolysis only a little bit of hemoglobin is released into the circulation and haptoglobin attaches to only a small amount of this hemoglobin, the levels of haptoglobin reduces a little. But in intravascular hemolysis, since lot of hemoglobin is released into the circulation, lot of haptoglobin needs to get attached to hemoglobin. So haptoglobin levels are drastically reduced. Now bilirubin levels. Unconjugated bilirubin levels are raised in both extra and intravascular hemolysis. Now where does splenomegaly occur? Yes, you are right. It occurs in extravascular hemolysis because macrophages in the spleen are working extra hard to eat up all the RBCs, and it does not occur in intravascular hemolysis. So splenectomy or removal of the spleen is useful as a treatment in extravascular hemolysis, but there is no point of doing a splenectomy in intravascular hemolysis. Now, reticulocytosis or increased number of young RBCs are present in both extravascular and intravascular hemolysis, as it is a common feature of all hemolytic anemias. As bilirubin production is increased in both extravascular and intravascular hemolysis, gallstones can be seen in both. In the next video, we look at a prototype of hemolytic anemia due to membrane defect, which is hereditary spherocytosis. Think at the cell level.